My name is Hallberg, and I am one of the medical directors at Virta Health. That would be my conflict of interest statement, and I'm also on the advisory board at Adkins. I also am the medical director and founder of the obesity program at Indiana University Health. And I'm a Aspen Health Innovator Fellow. And I'm thrilled to be here, and so I have to thank both SwissRe and the BMJ for organizing this. I think this is absolutely fantastic, and I love the opportunity to have a dialogue about some really important issues affecting both the health and the financial viability of not only the United States, but around the globe. So I'm thrilled to be here. So as far as type 2 diabetes, and I just want to make it clear that I'm going to be focusing on type 2 diabetes because that is what I do and what I am interested in. And first, I just want to walk through some incredibly basic, agreed upon things that then somehow escape even intelligent people when we move those things into guidelines, okay? And that is type 2 diabetes is what? It's a problem of elevated blood sugar. And although humans are different, and heavens knows we need to respect the differences, we cannot utilize a one-size-fits-all approach. We do have to understand that there are some things that are the same. And again, associations like the American Diabetes Association readily acknowledge, okay, in a disease where the problem is elevated glucose, that the macronutrient that elevates glucose is carbohydrates. Okay, so problem, elevated glucose, macronutrient that the American Diabetes Association acknowledges is the cause of elevated glucose, especially postprandial, which we know is a risk factor for coronary artery disease. If we want to not just manage with another pill, but reverse out of the disease process, we have to take away or significantly limit what is causing the problem. And so that's why the approach that I utilize is a low carbohydrate, and therefore, because there's 3 macronutrients, we have to balance this out, becomes a high fat diet. And we have a study that I'll be excited to talk about later that shows that this works very well. Now that being said, I'm also going to say to Roy that I'm a huge fan. And I think that what we can say is that there are 3 ways that we can reverse out of the huge epidemic of type 2 diabetes that the entire world is facing. Okay, there are 3 proven ways to reverse this: bariatric surgery, a significantly calorie-restricted diet, and a low carbohydrate, high fat approach. There are 3 things that work. And what I would love to see is consensus that reversal should be a goal, that patients should be given the choice of which of these 3 proven methods they would like to initiate and manage in their own life. Because patient A may choose surgery, and I applaud patient A that they're going to take control and do something. Patient B may want to calorie restrict forever. Fantastic. That is great for them as well. And a lot of patients, I think majority of the patients, and again, that's just my opinion, are going to choose a non-calorie restricted method of just reducing carbohydrates. And one of the main criticisms we get is that this is not sustainable. But again, we published our 1-year data, 83% still adhering. And we actually have proof of adherence through beta-hydroxybutyrate levels, which is unlike any nutrition study in the past. We always guess at their adherence, and we use the unreliable food diaries. We can show that they adhered. And we are going to be publishing our 2-year data soon. And I will tell you, adherence is fantastic. So again, I think the most important take-home thing is people have choices. Patients with diabetes have choices. They need to be educated that the choices exist and that the goal of reversal is real. They need to be explained all 3 choices that are evidence-based, and then the patient needs to be able to be the one to take control.
Fantastic. 4 minutes. Thank you very much.